Hello, everyone. Hello, everyone, and thank you for being here today. And I also want to thank the Mark and the Health AI Partnership for having me today. Just found out Sierra is my homegirl from Augusta, Georgia, so um, it's good to be working with you. Today, we want to talk about AI's role in. Let me get my screen together, please. So, hold on just a second. Okay. You can see my slides. So today we want to talk about AI's role in determining health of under-resourced communities. Again, I'm Dominic Mack. I'm the director of the National Center for Primary Care, professor in family medicine at Morehouse School of Medicine. National Center for Primary Care, we call it NCPC, but we work to strengthen primary care system, whether we're working with public health communities or internationally, like we do some work in Africa, but we work to develop programs that strengthen that primary care system through education, training, and implementation. We're about 90% grant funded. Um, so we've done a lot of work nationally, and now we're doing some work in Africa with the great team that we have. Today, these are our objectives. We want to talk about AI impact and the endpoints, technology as a determinant of health, disparity research, and digital frameworks. How do you detect and understand disparities? And we won't really use an environmental case as you know, get our point across, and then reducing disparities. We know what's going on in the health and the political and the social environment today. No matter how you perceive it, um, our point is the political and social environment may change, but the state of healthcare in this country and this world remains a reality. And we fight wholeheartedly for health equity and the underserved communities. It doesn't matter what community you're in. If you're without healthcare when you need it, that's a bad state to be in. That doesn't change because we're debating about how we should distribute healthcare. Our point of view, and I think a lot of you agree, is we need to give everybody good healthcare. But this is from Deloitte. They were trying to make the business imperative about the importance, especially to insurers and corporate, about they did a detailed study, and you heard these studies before, but this one was published in October 2024 that showed if we could implement some of these programs and really improve the distribution of care and other models to underserved and under-resourced communities. That's also under-resourced communities, meaning rural. Um, and it also means practices, under-resourced providers, practices in hospitals that don't have the resources they need. If we could improve that, we could add $2.8 trillion to the GDP, and we could really help the nation when it comes to healthcare. The U.S. generative AI estimated market size is about 4 billion now. This was from 2023, and of course, it's expected to grow annually. And you see the growth rate. But about 79% of healthcare organizations are presently using AI. So the cat's out of the bag. Um, Basically, AI is here to stay in some form, and we put it under the umbrella of digital health because it's in a lot of digital health projects, um, products, basically. You have AI, but you have also AI-enabled technology, which we'll talk about today. But the cat's out of the bag, and we have to find out how to use this most important tool toward the health of everybody. When you look at the growth of the market and cost, significant amount of cost in AI still remains because it's a lot of humans that are still involved. This kind of reminds us, if you remember meaningful use, electronic health records, and as a physician who was involved in meaningful use and the implementation of HIEs and electronic health records, I thought and we thought that we were moving toward a day when the electronic health record would help decrease the size of the practice and a lot of savings. Well, we've seen the opposite. Of course, the technology is most useful, but who goes into solo practice anymore, right? Everybody's working in a group practice or working corporate. The majority of our graduates now go into some type of um, healthcare practice with organizations. So electronic health record and other digital health tools still require a lot of human support and infrastructure in the practice. But I dare to say, when most people think about artificial intelligence, those of you who are also building it, and those of us on the clinical side of it, I think everybody goes back to that movie they saw, whether it be Matrix, whether it be all the other movies that you see about artificial intelligence being mostly autonomous. And, there are a couple of schools of thoughts, but, there's also the school of thought that AI should always have a human component, heavily involvement of humans, judgment, assessment and reassessment, as opposed to that autonomy. And this is a slide we'll revisit, and we want to look at qualitative health equity. And it can be qualitative health equity research as a tool. And what qualitative health equity is and what it means is, using methodologies and implementations to achieve health equity, a scientific approach. So this is the stepwise artificial intelligence approach that we kind of see, different formats to get to AI development. But what I'm trying to bring to the front on this slide is, where should we be at the end? Should it be an autonomous system? Should humans still remain to achieve health equity? But also the main point to the right of your slide, how implement health activities and processes into the development of artificial intelligence tools. So AI is out the bag. If we look at the definition of retrofit is an act of adding a component or accessory to something that did not have it when it was manufactured. Healthcare needs to move away from retrofitting health equity into technology and healthcare services overall. I've been involved in health equity, as a lot of you have been. Health equity is a retrofit in our health system. Our health system did not begin on the premise of equitable care to everyone. And when you try to retrofit things, it can be difficult, and sometimes it just really doesn't work. But what we're trying to say today is we need to, even though the cat's out the bag, we need to start making a right fit now. So let's talk about determinants of health. An understanding of determinants of health is foundational to the pursuit of the utilization of AI and the quest of health equity. When you look at the social determinants, which a lot of you know of, is education, access, healthcare, economics, culture, and neighborhood. But technology as a determinant of health, and some people would debate that, but I believe it's a determinant of health. At-risk populations, communities have access barriers to technology, and those barriers are included, as you see in the pictorial here, but also policies, whether they're at the federal, state, local level, or within the clinical enterprise, can also block folks from getting services, whether it be AI, more autonomous or AI-enabled services, but also the infrastructure of the health system and cultures and other factors that we'll look at. So when we look at the three levels, and this is something that Kilburn and co-authors developed a framework for health equity, and we kind of use this as our framework for the rest of the discussion today. And what they're saying is basically you need to detect them, if we're going to, of course, that's the first sign. You need to be aware and look for health equity, the disparities. So we need to detect them first. We need to understand them in order to reduce them. But the rest of the talk, we'll kind of use these headings and break it into these divisions to kind of make it digestible. But let's go straight to frameworks that we believe all of us should be looking at as we develop technology, but also as we develop artificial intelligence technology. AHRQ basically started with the health equity intentionality. And I want you to remember that word intentionality. And if you look to the left of the slide, who are the stakeholders? We always hear about partnerships, the importance of the healthcare system, but also clinical providers, policy makers, but really the community should be involved. But if you look at this second box, the digital healthcare equity domains and subdomains talk about characteristics of patient communities, health systems, and health IT. This really means what should we be considering as we develop tools, as we develop implementation, whether it be a clinical implementation, a community-based implementation, but also as we develop technology. And this was specifically from AHRQ. And I would hope you would go back and look at the framework in detail. But this is part of the intentionality that has to go into the stepwise process of impacting outcomes, such as equitable digital healthcare. And they've also given these general recommendations, for any organization or any entity. The organization needs to assess their readiness for digital health implementation. And in the case of artificial intelligence, no matter how you're using it and how much you're developing it, how is your organization ready for it, right? Evaluate the key drivers for health equity. Does the organization understand that? Is leadership on board? Then you, of course, have to identify resources and champions and make it, a serious charge to implement health equity in the products that you're producing, whether you're doing research or whether you're doing technology. There has to be a diverse workforce that handle it. If you're working in the American Indian community and developing products for that community, there needs to be some American Indians on your workforce. It needs to be diverse so you can understand equity, but also have people who have a sincere concern outside of yourself from whatever racial, ethnic, other groups that you're from. But the community needs to be involved. And we'll talk a little more about the importance of pipeline development. And then, of course, continuous improvement, that PDSA cycle we all talk about. Monitor programs, monitor equity, and see the impact on the community. Is it working? Now, this is a model that was built specifically for HIT by Zainab and Garba Sani. It was in Health Affairs, and you all will be able to look at these slides, but it's called Access AI Model, which ensures the advancement of health equity and make sure that it's community centered. This is heavily community based. It talks about affirming your aims. Why are you why are you developing this product? What communities should you consider and involve doing that development? How do you cultivate relationships with the community? And as you see early and often, embracing a multi-stakeholder approach. And then when it comes to the data, make sure that you have the scope necessary to serve the community, but also the community should be involved in and share in the data assets that whatever data is produced from the projects that you have. And then, of course, you kind of reassess and scrutinize all the spaces that you need to be in. But this is one of the community-based AI frameworks that are similar to AHRQ, but it's more specific for AI. And if you would, that article is in Health Affairs. So the overall message for this is that reducing disparities with technology requires a health equity focus throughout the design, the implementation, and the evaluation of any type of products that you may have. So let's move to the detecting disparities. To detect disparities, we must first organize our thinking about AI and AI's use in health services. And what this group did was basically classified in these three categories. You have direct end user technology, such as health portals, wearable devices. That's the technologies that you can just go pick up or purchase without prescription, with pretty much low access barriers. Then there's the direct use gatekeeper technology, like prescription drugs has to be prescribed by a health professional. And then you can have the indirect use gatekeeper technology. And basically, they divided in these categories to study innovations and the effectiveness of the innovations, basically in disparities, because innovations have been shown to widen disparities. And basically, the study was around that. But I like the way they organized the technology. And this is how you detect disparities by first beginning to organize your approach, whether it be e-health or m-health. And as we discussed it, there's access, but there's also utilization. A community or a person can have access to something, but they may not utilize it. It might be their own behavior, reasoning for not doing it, but it could be a clinic in the community, but the doors are closed. So access there, but is the population actually utilizing it? So access and utilization are important. But let's talk about the what and the who with that. Um, who are the gatekeepers and what are the things that keep folks are enhance utilization and access? We look to the right under the who, we have the patients, of course. A patient can be their own worst enemy when it comes to their health, of course. But care providers, policymakers, leadership, corporations can be the enablers or the barriers to health. And actually, especially autonomous technology, AI, you could see in the future where actually the technology, the artificial intelligence itself could be a barrier, become a who when it comes to determining access to technology. If you look to the left, you see the what's though. Policy, insurance, referral systems, health systems, of course, economics, and on and on, health, digital literacy, some of these things you know. But what I want to get across, which if you don't remember anything else from this, please remember value systems are central to equitable systems. The value systems of the individual and the value systems of the organization that's doing the work are producing the technology, are producing the artificial intelligence specifically. Um, the value system is important, and we would talk more about that. Let's review a short case presentation. Remember, it's not just health-based tech that determines health, right? So we're talking about determinants. The environment is determinant. So we want to review this short case just to bring a point across. This is concerning the environment determinant. We'll look at an AI-based solution also that has been developed. And this case will carry us into this discussion, which is focused on um, improving the AI model. So in 1999, I was involved in a case in Atlanta, Georgia, where an 8-year-old girl was burned on her arms and legs when she was playing in an Atlanta playground. And this was reported in the Atlanta Constitution. The Atlanta Constitution followed it up, and I just highlighted some of the article. Later, in 2010, they interviewed the who was a young girl. Now she was a young lady who was actually burned. Um, there was an explosion on the playground. She was a pigtail second grader. She ended up in the hospital. And when they interviewed her, she still had scars from the burn. And you see a quote, I felt the slide pop up. Norman recalled last week. I was really, really scared and shaky. Once I got off the slide, I saw the steam come up from the side. She saw the steam coming up from the slide, but the blast was so powerful that it just knocked her off um, the swing or the swing set, and it burned her at the same time. Now, the point is for this is the father of environmentalism, Dr. Robert Bullock, was at Clark Atlanta University at the time. And Dr. Bullock was called in by the community to help the community. I was the CMO at a federally qualified health center. And of course, the community was right. We sat in that community. A lot of the community was our patients. So we were asked to come in and to work with the community to eventually work with the municipal leadership to get some resolution. And there was some resolution. This was in Fulton County. But this is a good book that talks about the inequities in dump sites and where dump sites are actually put, mostly around underserved communities. But there have been disasters, no matter what color you look at. They've built some high price communities on some of these, but the majority of dump sites and these types of accidents and exposure to toxic waste and things are in under-resourced, underserved communities. But Atwater and authors, first I want to just kind of tell you about why it's important, why it's a determinant. Of course, we know dumping sites. We can ride down 285 in Atlanta and some other highways and smell the pollution, but also smell the odor pollution. But there's air pollution, of course, underground water pollution that you may not even see, and then marine runoff pollutions. But there are long-term impacts from infectious disease, which could be acute or chronic, to behavioral and neurodevelopment problems in kids, lung disease, diabetes, cancer risks, you name it. The list goes on, and we have some, you can go see some of the articles and see more about it. So the environment as a determinant of health, living close to a dump as a determinant of health, is what we're trying to bring across here. But we wanted to look at this case. Otwad and authors introduce an AI framework that uses algorithms that include community variance. What they did, they developed this landfill site potential index and did geo mapping. And basically, they used some socioeconomic factors to develop the AI tools. Using multi-criteria analysis. They also used focus groups with the community, but mostly the factors that they considered were geographical, not putting it next to a school, not some roads, not putting it next to a health center. But this is a good start when it comes to artificial intelligence, even though it's a determinant in the environmental. Some people would think it's non-health related, but this shows the importance of AI, not only specifically health AI, but also AI in those fields of the determinants, like environmental. But what we want to do is take this model and let's apply it to the larger health system and see how we can develop models like these, but also enhance models like these to really help the patient population that we're trying to serve. So I told you to remember that about intentionality and remember about that when it comes to values, the importance of values. And that's why I presented this environmental case. This is a theoretical framework called the value belief norm theory. And of course, it deals with what's happening in the environmental, But when you look at your values, where your values be about the environment, about helping other people, or just self-centered, you develop an ecological worldview. And then that's impacted about your awareness of the problem, right? But then it really comes back down to the individual. And then this is personal, but also corporate. What is my responsibility in this picture? And what is my obligation? And so that leads to my behavior, activism, or non-activism, or whatever I may think about that. But if we march this out and start looking more at health and health technology, what's the impact of value on the way we produce our products, the way we implement? So the definition of cultural equality is a set of values, policies, and practices that ensure all people are represented. So you ask yourself, do you believe that? Does your corporation believe that? And you can do this with a number of things when it comes to equity. But we're going to talk about personal, but let's talk about corporate right now. So what is the values of an organization? What's the values of Morehouse School of Medicine? If it's in our mission, in our vision, in our mission, but how do we live it every day? Is it in our policies and is it in our practices, right? Of course, you can have values or say you have values, but you don't have the policies to put them in practice. So this is just a stepwise way that I would invite us to look at how we implement cultural equality into the technology and whatever work that we're doing. But let's look at you as an individual. And I personally think, of course, everything starts with the individual, and then we come together collectively. Now, as you see in our beliefs, we're heavily influenced by peers and our mentors, etc. But it comes down to things such as faith, culture, education. Our experiences are so important. For instance, if somebody's had violence or other things against them by another race or something, that can be very impactful in their beliefs. But your beliefs definitely affect your attitudes, what you think about it, just like with environmental. And then your attitudes affects your behavior. So this is whether you're working in an artificial intelligence, a company that's producing artificial intelligence product, or you're working in the health system or academic institution. I will ask you, when it comes to cultural equality, what's your belief, your attitude, and then what is your behavior? And individually, we come together collectively. And then this is how we define the AI tech that we produce. This is how we make clinical decisions. When a physician is sitting by that patient, it's just a physician and that patient, and the physician makes a decision based on the color of somebody's skin, or not make a decision based on the color of somebody's skin, whether they're disabled, et cetera, et cetera. It comes down to the value system and putting policies corporately in practice. So spend about 5 more minutes, and I want to spend a little on this and then kind of show you something we worked on. I really want to hear from you all, not just about this, but anything you like to share with each other. I'm not the expert. We all have something to share. So I'd like to hear from you. But so remember the model we had at the beginning, the steps we had at the beginning. And when you consider, and that's what I want to use for our discussion, what is the end point of qualitative AI, a qualitative equity in AI? I do believe that it's always going to have to be human values in this assessment, reassessment. I think it's going to have to be always some oversight, heavy oversight, when it comes to just reevaluating to make sure that we have community involvement, because the needs of the community change, and the communities who are of need changes. Um, and those communities need to be involved in this conversation. So to be responsible, responsible AI, ethical AI, look at the box to the right. I truly believe that values for cultural equality, the values, those core values, the intentionality of the corporate, of the company, um, basically will lead you to do these things within the company. But what do you also advocate for outside the company, whether it be pipeline and workforce development, community funding, with federal grants and state grants and from private institutions? Communities need direct funding. It doesn't always need to come through, especially majority entities for underserved communities. And that's including rural, urban communities for rural to communities are of need. Um, Primary care and behavioral health and substance use. Um, Speak plainly, we talk about the immigration issues that are there today. What's driving that? There's a heavy substance use and problem in the United States, which we really have to take care of. So the system has become specialty focused and more of a production for AI and technology, really for high-end specialty healthcare. But we really need to keep behavioral health and primary care in the forefront. Prevention is really important. Then we have to consider the history of communities because, as I've stated before, innovations traditionally widen disparities. And if we study that, when we produce new innovation, we can make sure it's not doing that. But there's just how has this community been impacted? Why won't they utilize certain services? Understand the culture in the communities that we're working with and involve them in the workforce. So you can see the rest of it, but it should start at the problem and definition field. And I haven't talked about algorithms, but who's making the algorithms, who's involved in it, who is it made for? You need involvement from the start all the way through process. So I'll end with these few slides. This is what we've done at the National Center for Primary Care in Morehouse School of Medicine. And this goes to reducing disparities. And always, pedal framework is one of the ones, is a foundation of some of the work we do. It's a learning health system model. And basically, we prioritize, engage, we target, we act, and we learn and improve. It's actually published and you can look up the model. But I'm gonna talk about another publication, which we've recently had in AJ, PH, American Journal of Public Health. But we used the pedal model to develop the framework for the National COVID-19 Resiliency Network, which some of you may have heard of. It was a significant grant for OMH, which Morehouse School of Medicine received. We had to work at the beginning specifically with African American, Alaska Native, American Indian, Asian, Pacific Island, Hispanic, and Latino, and other disproportionately impacted communities. Was the initial charge from OMH to identify and engage these communities, create information and dissemination networks, develop culturally and linguistically appropriate information to kind of overcome those barriers to vaccinations, care, et cetera, but really to link these communities to care. And then, of course, monitor and evaluate what we did and bring awareness through publications, education, training. Partnership was key. You can see some of the partners from all of those different racial and ethnic groups, including those with disabilities, et cetera. And this shows the percentage of the partnerships. This is published in Special Journal of the AJPH, which you can go take a look at. But we involve partners almost proportion to their percentage in the general population and sometimes greater. But you see, they were all involved and they were involved from the beginning of developing this model. And with this model, we also developed technology and worked with KPMG, Salesforce, and Comcast. And we had some AI-enabled technology involved in the communication tools, which was, really more than a website, but also we had a mobile app. Um, we had over 30 languages with this tool, but it was built with the input of those partners that you saw. And also, we had a subgroup of research partners who were involved in research, some from community-based organizations, some from academic institutions. We had over 400 partners across the nation. But as we built a tool that had AI-enabled technology in it, we got feedback from these communities and we involved these communities. And we also made sure with our partners that they had some minority community involved in the development of this project. There was a resource locator. You could find resources in your community, whether it be vaccinations, mental health, etc. And of course, a lot of AI was involved to help with this model. And then, of course, education materials were produced to overcome, some of the myth, but also to inform. So thank you. I want to leave it there, open it up for some discussion. We'll stop sharing my screen. And thank you all again for being here. Sierra, I turn over to you, I guess, for any questions.
Thank you so much. Thank you all for your attention. Well, like Dr. Mack said, we'll open the floor to questions. You can either raise your hand to ask your question or drop it in the chat. And just one call, then please introduce yourself briefly before asking your question. Maybe I can get us started. I have a quick question. So
Okay.
you talked about technology as a determinant of health, and particularly one where we see a lot of inequities. When you're involving communities in designing AI tools or products or solutions, how do you mitigate maybe some of that knowledge or power imbalance to make sure that people are designing on equal footing?
Well, I really think we have to probably a step further back than when we think about the development, we think about the company, the entity that's developed. I think we have to step back to the pipeline development. I really think we have to be intentional of making sure that um, the young folks, the children, young adults, etc., from the underserved communities are involved educationally, academically, um, in technology, in pursuing fields in technology. And of course, also specifically in AI. So we know you need a workforce in order to hire. You can't hire anybody off the street to develop this. So I think it has to be an interest in developing the workforce and for corporate to be involved in that academic development, whether providing funds toward it, um, or some type of community programs for that. Another piece is it has to be intentional, of course, from an HR perspective. But as I pointed out, leadership has to be intentional about it. And it goes back to that value system in order to make it, something that the company will pursue and sustain.
Absolutely. I see we have a question in the chat. So Kate asked, how will technical solutions be maintained or sustainable?
I missed that. How will what now?
How will technical solutions be maintained or sustainable?
Um, I guess technical solutions when it comes to health equity, I believe, maybe. Um, it comes back to intentionality. Again, not to bring up anything political, but right now we know DEI, however you look at it, that was a tool supposedly to achieve equity when it comes to workforce, especially. But we know now that's threatened, right? So sustainability long term can be impacted by different things, again, about especially when it comes to the federal government. If the funding, most of the funding is from the federal government, we know even outside of that, um, the target of the day can change. So I think it has to be partnerships, for profit and nonprofit partnerships to kind of sustain the resources that we have for this. We have to be strategic and not depend heavily on just one source for our funding. Um, but it does come back to resources. Are you able to sustain? It's just like in clinical. I was in the clinical system and medical director for years. The first thing to go would be the social worker. It was just it. That's really the most important thing that you need, right? But the social worker would be the first to go when resources got cut. So how do you sustain? Somehow you have to figure out how to be strategic and have multiple ways of maintaining these resources. But that does take intentionality from the leadership. Ayush, is that correct?
Yeah, yeah.
Yes, sir.
Hey, Dr. Mack,
How you
thank you for
doing?
your presentation.
Thank you.
My name is Ayush. I am a junior undergraduate student studying here at Emory University. And you prefaced your presentation with a statement that um, we all believe that healthcare should be equal. It's just we differ in how healthcare should be like provided or given. And so, like, just being as like vague as possible, given that there's incoming like administrative changes, what are ways that like current tools that are being developed and previously developed tools can like remain intentional, remain intentional about keeping diverse perspectives as part of the development and deployment process?
Oh, thank you for that. Um, yeah, what I intended to say was that the political and the social environment would may change, but the need in the community remains the same. Now, I really don't believe we all believe in health equity. So if I said that, I didn't mean to say that. But what I was trying to get across is that the problem remains the same. Um, and but yeah, again, how do we stay intentional? I do think, like especially during these times, if you believe in it, we have to continue to push for it um, politically, socially, um, and we have to know what are the factors that influence it, right? It's influenced at the federal level, but it's also at the state and the local level. And like I say, the organizational level. Like you at Emory, we're at Morehouse School of Medicine. You as an entity and others can push for policies within the institution that really support sustaining equitable implementations, whether it be technology or just be programs, right? Inclusivity of workforce and student body that serves everyone. I think we just have to continue to be a voice. And that's why I say everything, the values are corporate, but they come back down. They start really with individuals. And individuals come together to make a corporation. Peer influence is real important. But I think more of us have to really stand up for what we believe in and just continue to try to push and advocate. But it comes down, you got to get somebody here to get the resources. And resources not always money, right? But to get the resources to sustain whatever you're doing.
I appreciate it. Thank you.
Hope I answer your question.
Yeah, yeah.
I
Thank you.
see we have another question in the chat from Christopher Deutschman. He says he's a research associate in a small lab at a large hospital. How does someone in his position make a difference when they have a value at a personal level to embed health equity, but there is little practice at the corporate level to pursue equity?
Yeah. Um, I think you have to realize when you can't change, when you can and when you can't change, right? Um, just let me just, when you got a job, you need your job, right? So you can only you have to when you within an organization, it does come down to you have to there's a culture, right? You're in that culture. You can't just change the whole culture in one swoop. Um, so you do what you can diplomatically, practically, respectfully. And then it may come to a point where you realize you can't do it within that environment. But if you're the lone voice or it's just a few voices, or you don't think it'll change, and you've done that, you put your best foot forward in the right manner. Yeah, you have to look sometimes and see if you may need to make a change. Because in the end, corporates, especially privately owned corporations, have the right to put into place policies that they believe in. And sometimes that might not be the place for me to work, you know. But think strategically, save up your money, then leave. I mean, if it comes to that. I'm not telling you go do that now, right? But I'm just saying if that's it, but if not, if you see you could change and it's an opening, you do that. But of course you don't want to put your livelihood at risk.
I see we have another question in the chat from Senna. She said, how do we build trust in health-related digital technologies to mitigate inequity? I think this is another great question I had, really, especially in light of historical injustices and maybe some justified mistrust.
I think we have to educate, if you go back and look at that value system, and that's what I like so much about the environmental theory diagram. It just tells you, people have to be aware, right? Some people are not on board with things because they're not aware. So they have to be aware and educated. And sometimes you're just part of one aspect of that, right? We're part of that at the NCPC. We have some programs that are just all about awareness and education, whether it be of communities or whether it be of like corporate other entities. But you have to be in the room um, to try to get folks to change. But I think we just have to continue to use our voice. You have to stay in the political game. We have to vote, right? We have to do all those things that help us to have a seat at the table. And especially at times like this, just don't withdraw because, for some of us, it seems like the battle um, is not going in our direction. So and Sierra just talked about historically, and if you look historically, how we were able to make changes and change the minds of folks. And I think this is one right here, HIP, is having talks like these, organizations like HAIP, basically these type of organizations can really be a voice to kind of help. So be a part of these type of organizations as well as speak out where you can, where you work, and then socially, are you involved? I think we have to keep pushing, and historically, that's how we've been able to make change.
Absolutely. Thank you for that. Any other questions? Okay. And thank you, Dr. Mack, so much for the talk and for your presentation today. Oh, I do see we have one more question from Kate. She said, data can be a source of distrust. What recommendations do you have for handling data?
Yeah, that the stepwise process at the end on that probably the 6th from the last slide, it talks about being informed, being part of the definition process when it comes to AI. You look at AHRQ's model, it's pretty much, when you think about the stepwise process of planning and developing technology, or even when you, of course, we use technology a lot to get data, but even if you're doing a data management program, et cetera, we need the right minds involved at the development of whatever project or initiative it is to make sure that the collection, the sharing, and the evaluation and the reporting of the data is fair. As we know, especially in the scientific world, you can get one publication that's about to change the world, and tomorrow they use the same data and come out with something else. It's kind of like, in a sense, the way you slice it. But you have to have people in the room that trustworthy, honest, but also would make sure we're extracting comprehensive data that shows a truthful picture. Because we all know you can extract certain portions, certain data and make it look any way you want to. So we need the right folks in the room, and we need to start at the beginning of this. We need diverse workforce, and we need to be included in the definition of these projects, initiatives. Yeah.
I see. We have another question from Ada. I hope I'm pronouncing that correctly. So, do you anticipate having to make any specific changes to the way you practice medicine to incorporate health equity?
And I'm not practicing day to day now, but definitely work around a lot of practicing physicians and have a good thing on what's happening in the clinic. Today, even though we have electronic health record, we have access to a lot of data, it is a little difficult today because of the demand of the system. You might be a clinician could be in a clinic where they need to see 30 folks a day, and it's hard to really spend that time with the patient that they would like. But I would say there are a lot of tools out there that you can turn patients to, right? Only 10%, some people say 15, 20, only 10% of your health is determined by healthcare. 90% of your health, 80 to 90% of your health is determined by basically what you do in the community, right? The best thing a physician can do for a patient is teach the patient how to help themselves, where they can get technology. And we talk about under-resourced community, but there have been studies, and seen studies before, especially in the African American and Latino community. They have more smartphones than they did, designated smartphones as they do in the white community. So we're all connected to technology, right? So I would say, as health professionals, doesn't have to be the physician, but connecting our patients to information, health information, and giving them, the prevention tools that they need, like getting your mammogram and things like that, connecting them to the information where they can really help themselves, is one aspect. That's a big conversation, but I think that's one thing that we can do a little better, especially in a system that doesn't give us as much time. Because when I first started, you could sit in there for 30 minutes every patient. But you just can't do that anymore. And use your team, right? You got a team, you can refer to the social worker, you can refer to the nurse to do some of that. Use that team, but teach the patient how to help themselves.
Thank you so much, Dr. Mack, and thank you everyone for joining today. Really appreciate the time.
Thank you all.
Have a great line, everyone. We look forward to seeing you next month.